We'll now move ahead with the next lecture that's to be delivered by Dr. Ravi Kasliwal, Chairman of Clinical and Preventive Cardiology and Community Outreach and Education from the Medanta de Medicity in Gurgaon. He also happens to be the President of Indian Academy of Echocardiography. This afternoon, Dr. Kasliwal joins us to speak on vascular stiffness, most powerful predictor of coronary artery disease, for the next 13 minutes.
Chairpersons, good afternoon. Good afternoon, everybody. I know you're all sacrificing your lunch. On discussion with Dr. Chopra, he'd asked me to speak on hypertension beyond BP control, and just to discuss with you briefly the concept of arterial stiffness assessment. Is it required? Is it not required? So the first few slides are truly what we already know about hypertension, the consequences, the large studies that have been published. In any clinical examination, if you look at it, taking pulse, heart rate, blood pressure, and a clinical examination is the initial step in evaluation. The data about hypertension and CV risk is well defined. Coronary deaths, CV deaths because of hypertension, well known. It's one of the significant public health problems, we know that. And as the blood pressure increases, the mortality increases. This is old Mr. Fit data of 2002. But is brachial pressure, the pressure that we take routinely from our arms, is it equal to central aortic pressure? And should we actually even measure it? Is there even a situation where we should do it? So in the next 9-10 minutes, this is exactly what I'm going to talk about. Why measure brachial? If central aortic pressure is so important, then why should you measure brachial pressure? The main reason is ease of measurement. So the ancient Indian and Chinese medicine, thousands of years ago, they could, we have Hakims who could, just by putting their hands on the pulse, would be able to say what disease the person has. And then Jules Marie actually invented a sphygmograph to actually record the arterial pulse on smoked paper. So that was actually the beginning of arterial pulse tracings. And Riva Rossi introduced the mercury sphygmometer, measured systolic blood pressure, and then came the famous Korotkov sounds, and that changed the whole picture. We could now get two simple numbers, systolic and diastolic. It was easy to use. So the pulse wave analysis, which was started so many years ago, fell into disuse. 20th century saw tremendous gains from simple sphygmometer and the dangers of high blood pressure. This is what we are at the present time. But if you look at vascular physiology, it's not as simple as that. Just as Dr. Nanda said, heart is not a pump. It is like wringing a towel and getting the water out of it. So similarly, vascular physiology is something different altogether. And let's see how this functions. For example, when you have the left ventricle contract, the blood goes into the aorta, which expands, and you see a systolic wave which moves forward. It goes to the periphery, and it comes back. And it comes back during diastole. This is the hallmark of a compliant vessel. Now, I've written here young compliant arteries. Young doesn't mean age. We are now seeing heart attacks at age 30, 28, severe hypertensions. I'm sure they don't have compliant vessels. Compliance is just that there is normal pulse wave velocity, and I'll come to that. So, in the compliant vessel, whereas in a stiff artery, it goes and comes back in systole, which means that during diastole, you are depriving the heart of the major amount of oxygen that it gets. So if the contraction takes place in systole, the reflected wave comes back in systole, then it's a stiff artery, and this increases the pulse wave velocity. Now you see, we are just measuring the blood pressure at the brachial artery, how much we can miss in certain individuals. When the blood pressure, pulse reflected pressure wave comes back in systole, it increases the load of the myocardium. It causes LV hypertrophy, and it actually causes increased myocardial upstroke, increased myocardial requirements. That is the difference between a compliant artery and a stiff artery. In a compliant vessel, as you can see here, the reflected wave results in augmentation of the diastolic pressure. And as a result of that, you actually enhance filling of the coronary arteries, which takes place only in the diastolic phase. So arterial stiffness and central aortic pressures are two important variables. And you can understand that only by understanding the way the waves come in and go. Wave returns during diastole in compliant arteries, wave returns during systole in a non-compliant or stiff arteries. That is the basic difference. The pathophysiological significance of arterial stiffness then is that the stiff arteries causes inability to expand during systole, increases systolic blood pressure, increases cardiac work, and the loss of recoil during diastole causes decreased diastolic pressure, causes decreased coronary perfusion. So arterial stiffness results in an unfavorable ratio of myocardial perfusion to cardiac overload. Just as people have been talking about lifestyle diseases, in a young individual, metabolic, obese, having high blood pressure, if this starts occurring at the age of 25 to 30, then you can know that this individual is going to have the ravages of hypertension, stroke, heart failure. One of the commonest reasons of heart failure is actually systolic hypertension. So more importantly, the stiffness of aorta and the dynamics of the reflected wave, particularly its timing, will determine how different brachial BP and central aortic pressure is in a given individual. Let me skip through these, but let me say that an expert consensus group on arterial stiffness in 2007 said because of pulse pressure amplification between central and peripheral arteries, it is inaccurate to use brachial pressure as a surrogate for aortic or carotid pressure. Now, you may well say, look, I'm getting adequate risk response from a brachial. Why should I go for this? In high-risk individuals, those with multiple risk factors, it may be a good idea to go beyond BP control by just the brachial artery, but go and look at the central aortic pressure. Because you may have controlled the pressure in the periphery, yet the central aortic pressure may be high. Pathophysiological significance of arterial stiffness. Increased arterial stiffness gives rise to increased central blood pressure and increased central aortic pressure. And this will give rise to nephropathy, LVH, CAD, as I said, CHF, and stroke. So you may be quite comfortable that the person's blood pressure has come down in the periphery, but the central aortic pressure may still be high. So to make things easy, there are only two measures of arterial stiffness: aortic pulse wave velocity, that's the PWV, and the central augmentation of index. Central augmentation index. One is a regional arterial stiffness parameter, the other is of the entire arterial system. This is how carotid, once the heart contracts, the blood will go to the carotid. That's where the carotid incisura reflection is. That's by the time it comes to the femoral artery. And the difference between the two is the delta T. That is the difference. That is taken as the delta time, and the distance is from the carotid to the femoral. That's the distance, and that gives you. So the pulse wave PWV position statement, pulse wave velocity, is considered as the gold standard measurement of arterial stiffness. And this is the central augmentation index. Very simple. You take the height of the late systolic peak pressure. Mind you, this is in isolated systolic hypertension. The pressure wave is returning back in systole. It is adding to the burden. So you have the augmented pressure, you have the pulse pressure, you divide that, and you will get the central augmentation index. So if your antihypertensive drug is decreasing pressure in the periphery, that pressures may be coming down, but the central augmentation pressure is not down, and that is what actually measures the LVH burden and stroke indices. So, as the time is short, I will just say that it works both ways. Sometimes the central aortic pressure may be so low, and the patient is complaining of complaining of fatigue, though the peripheral pressure may be high, and that may be as a result of low central aortic pressure. So these are easy to measure. We are in touch with Dr. Cockcroft from Wales and other European centers, and we are working together. In fact, one of the journals that we have given talks about central aortic pressure, and so this is the relationship of arterial stiffness and hypertension and management in North Indian urban population. They say that arterial stiffness is significantly increased among hypertensives, positively correlated with both systolic and diastolic. So it's not just ISH. All measures of arterial stiffness improve with control of BP. Assessment of arterial stiffness may thus be helpful in tracking vasculoprotective effects of certain drugs. So take-home message, increased arterial stiffness is associated with end organ damage. We know that, and is an independent predictor of CV risk. Central BP is pathophysiologically more relevant, and current non-invasive, validated, easy-to-use techniques can actually estimate central BP and wave reflection indices, and with good reproducibility. So central BP and pulse wave velocity provide incremental value in prediction of CV events, assessment of therapeutic efficacy of antihypertensive agents, and selection of appropriate agents, as different classes of drugs have actually different effect on blood pressure. Thank you, ladies and gentlemen.
Thank you very much,
Thank you, Mr.
Dr.
Chairman.
for the speakers and the chairperson. It's over to the chairpersons. Thank you.
Sir, how insomnia produces cardiovascular events?
Yeah. There are a lot of data now coming up.
Sir, I am Dr. Gurdeep Singh.
Just 1 minute.
I want
Can
to
I
ask
answer?
one question. Sir, what are the drugs which can be used to reduce the arterial stiffness?
The question was asked about sleep disorders. Well, there's a whole day you can discuss sleep order. Sleep disorders now are a risk factor for hypertension as well as coronary artery disease. Initially, it was thought it is obstructive sleep apnea. That everybody knows. It is a risk factor for hypertension and all. But now, inadequate sleep is also important. If you do not have a sleep for 6 to 7 hours, you can get this. And the quality of sleep is also important. So a lot of emphasis on sleep is being mentioned these days. And there is a reason, maybe stressful conditions, all those hormones, etc. And so, yes, now.
May I just add something to that?
Yes, yes.
The question of sleep is very important. There is a Wisconsin heart cohort, sleep apnea cohort, in which they are seeing patients not only with sleep apnea, but also those who have fragmented sleep and other sleep disorders. And they are finding consistently that those who do not take proper treatment actually become hypertensive. They increase their intima-medial thickness very early on. So sleep, I think, is now an important risk factor for cardiovascular disease. That's what I feel. To answer your question, which drugs actually decrease arterial stiffness, 2 drugs are very well known. That is, one is amlodipine, the other is perindopril. So that means some form of ACE inhibition helps in, or ARBs do help in peripheral, in decreasing central aortic pressure.
Yeah, I want to make a comment. Actually, Dr. Manchanda showed good data showing us about anxiety, depression, and psychosocial factors which would increase the event rate. Now, obviously, when we see patients of ACS, almost 30% of the patients, you would find that they were anxious before they had the acute coronary syndrome. They had some problem or the other, work stress, and even after having, because once they know that now they have a coronary artery disease, generally majority of them, they tend to have more, either they would have anxiety, they would have depression. So this is seen in almost 30% of the individual who would require treatment for depression or anxiety. And obviously he has shown the data. So obviously majority of the patients, majority means it's a 33% is a good majority, where like once the physician feels, he should add the drug so that the patient has the benefit.
Yeah, the counseling should start immediately after myocardial infarction. There's a lot of data, patients who are depressed seriously after myocardial infarction, the mortality is markedly high. And therefore, you should give drugs. The drugs data is unfortunately mixed results. And therefore, we have started a project on yoga as cardiac rehabilitation. I think results will come in 4 years. We believe yoga meditation could take care of many of these factors which are there. This study is just started. It is a all India international study, actually England and 16 hospitals in India are participating. And we hope that meditation, yoga, as we are listening, could be a very useful tool after myocardial infarction and so on.
These young boys who are having high job profiles, they come with infertility. There is increased incidence of infertility in these.
Every system of the body is affected, and whatever your system is weak, it manifests that. I was talking about the heart disease. I agree with you. Because the whole biochemistry, the whole neuroendocrine system is changing, therefore it can affect the whole body, and therefore stress is the biggest enemy of mankind. And if we believe the data which was presented this morning, it is highest in India. 80 to 90% of Indians are having some sort of depression or anxiety. We should be very, very careful in controlling them.
Yeah, Dr. Kasliwal, does statin would it have any effect on the arterial stiffness?
Yes, yes, very positive. The gentleman asked me about antihypertensive, but very positively.